So this talk, look, I'm not, okay, here's the advantage of being a course coordinator. I conveniently placed myself in the middle of two very senior, very experienced hematologists, just like yesterday I did in the gastro session. So any hard question, I'll just do this. The point of this talk is not, to begin with, I'm not an expert on this topic. I've seen two in my entire career in the last 10 years, but the first one, Sandra, I almost missed. And that's why I thought that it's so easy to not pick up these cases. And timing is extremely crucial in being able to treat them. So in fact, whether they're going to live or die, I think depends on how quickly we can diagnose them. Okay, so learning points, basically difference between MAHA, TMA. What are the differential diagnoses of conditions which can present with MAHA and TMA? And the main ones, when to suspect, and also be aware that there is drug-induced and metabolism-mediated. I had very early on in my career, I had seen a vitamin B12-induced TMA. So what's MAHA? It's basically hemolytic anemia, which is due to intravascular RBC fragmentation. So you got to pick up a hemolytic anemia, which is Coombs negative, and your hematologist colleague will tell that, oh, I can see schistocytes, and you got your MAHA. That's microangiopathic hemolytic anemia. It's mostly, as we know, it's mostly due to abnormalities in the arteries or capillaries when we call it TMA. But remember, it can be due to things like prosthetic heart valves. Or there's that example of soldiers who have marched for 40 kilometers and they ended up traumatizing their red cells. So how does the patient present? The patient will present with anemia. You would have done your vitamin B12, folate, iron studies, and they were all negative. And then you thought of hemolysis, and then okay, low haptoglobin, high reticulocytes, looks like hemolytic anemia. And then the Coombs is negative. It's not possible. Negative Coombs test, and your hematologist colleague will tell you there's histiocytes. So remember, not all MAHA is caused by TMA, but almost all TMAs cause MAHA and thrombocytopenia. I mean, there can be TMA restricted to the kidneys, but that's really very, very uncommon. So what's TMA? TMA is basically microvascular thrombosis due to abnormalities in the vessel wall. So MAHA could be TMA, or MAHA could be also be due to things like prosthetic heart valves. And TMA is always microvascular thrombosis, which is due to abnormalities in the vessel wall. So injury to the endothelial cell is the pathophysiology. Clinically, as I said, they present with hemolytic anemia, schistocytes, Coombs negative, and thrombocytopenia, and variable organ injury. We'll see that in a minute. It is primarily histological diagnosis. Okay, you need tissue. So in my world of nephrology, we get our renal histopathologist to tell to confirm. But having said that, many a times with the clinical presentation and lab features that you see, you might not actually need a biopsy. But if you were to do a biopsy, this is what you would see. So differential diagnosis of MAHA with thrombocytopenia. And there's a primary conditions on the left side, but I wanted to look carefully at the secondary conditions. I have a young woman who is on dialysis in our unit who every couple of months she presents with a blood pressure of 220 over 120 or something, doesn't take her medications, and she behaves exactly like this with MAHA and thrombocytopenia. So severe hypertension. Think about things like DIC. Also think about things like the calcineurin inhibitors, which many of you would come across, cyclosporin and tacrolimus. And of course, pregnancy associated, lupus, systemic sclerosis, etc. On the left side, these conditions we are going to go around now. So the first one we said is TTP. So usually previously healthy individuals, the thing that I guess differentiates TTP from the other ones is that the AKI is actually not severe, but the thrombocytopenia is very severe. And I think that kind of differentiates it from the other conditions. So the creatinine mostly would be less than 176, but the thrombocytopenia is going to be profound. There will of course be many, I think 60 to 70% of them have neurological dysfunction. So I remember 10 years back, books would say the classic textbook pented of thrombocytopenia, MAHA, neurological abnormalities, fever and renal dysfunction, but that is, I don't think that's seen a lot really. 3 per 1 million adults per year based on this registry. And this comes in younger people, females more, high fatality without treatment, 90% with prompt treatment. Has anyone come across TTP in this room? Yeah, so we got a few people who have seen it. So presentation, so as I said, the platelet count is going to be seriously low. They're anemic, of course, and remember Coombs negative hemolytic anemia. A lot of them have GI symptoms, weakness, bleeding, purpura. About 60 to 70% of them between major and minor neurologic finding will have some sort of neurologic findings. 14% of them can have cardiac presentation as well. Pathophysiology, I think all of us know endothelial cells makes von Willebrand factor. ADAM-TS13 is supposed to cleave the von Willebrand factor. If we do not have enough ADAM-TS13, the von Willebrand factor accumulates, forms a mesh-like thing in which platelets get trapped, leading to thrombocytopenia, and then RBCs get trapped. As RBCs travel through that mesh-like thing, their heads get chopped off, and you get cystocytes. Mostly it is a autoantibody driven process rather than genetic condition. The reason I mentioned this is when you go to the next entity, which is complement mediated, you will see that mostly it's a genetic condition. Diagnosis, again stressing severe thrombocytopenia, less than 30,000. The next line you all know, schistocytes, so usually 2 or more per high power field. ADAM-TS13 activity has to be less than 10%. Creatinine usually less than 170. Very rarely do they go with severe AKI. Renal biopsy, I don't have to talk about this, but this is the classic presentation which you will see actually in all of the TMAs. Just out of interest, if someone is interested, you can see those platelet thrombi. Now, the million-dollar question is, let's say you got your patient and we do not have a ADAM-TS13 result yet. So Sandra, here you would remember the first patient that I picked up in Blacktown Hospital. I think your Newcastle people do the ADAM-TS13 level. So I remember telling Serge, who was my BPT, call them, beg with them, but get the ADAM-TS13. And I'll tell you, I almost missed that patient. I'll come to it. So beg, call up and beg for ADAM-TS13. So, but let's say you're not getting the ADAM-TS13 in the next 24 hours. It's crucial to start treatment if you suspect it's TTP. Then please use the plasmic score. So I'll let you look at that. Let it sink into your brains, I guess. There are 6 points here. 5 or higher, you empirically treat for TTP with plasma exchange. Okay. So the first patient that I almost missed, she was a 64-year-old woman who basically came in dyspneic, short of breath, looked classically fluid overloaded. So initially the cardiology guys got involved. Then they found a creatinine of around, I think 200, 220, and she was anemic. I think around 4 o'clock, the hematologist actually called up saying that, oh, we can see fragmented RBCs. By that time, we had been involved as a renal team because the creatinine was 200. This was a new finding, and we said, oh, no, I don't know what's going on, heart failure, let's do this, let's do that. We did not think of TTP, okay? Because that woman at that stage had a platelet count of 200, so 200 something, 210 or 20. But once hematologist called up and saying that it looks like we've got fragmented RBCs here, so we are looking at some sort of microangiopathic hemolytic anemia. Then I went back and looked at her platelets. So 2 months before that, she was in the hospital. She was in ED with something else unrelated. She had a platelet count of around 500. So from 500, she had dropped to 200. So then we begin to start thinking, uh-oh, are we looking at this? But when Serge called up begging with you guys, and full credit to you guys. By that evening, you gave us the numbers. But in the meantime, we looked at the plasmic score. So her platelet count was more than 30,000. Her creatinine was 200. So I was kind of confident that we do not expose her to TTP. Remember, TTP is not entirely without its risks. So that woman was, and we'll talk about that. So management of TTP, basically plasma exchange, prednisone. I'm not going to go into a lot of details here. Rituximab. See, the important thing is being able to think of it and to come up with a diagnosis. Treatment, you can open your up-to-date, you can open your resources, you can find out, because these sort of cases you're not going to see a lot. But the day you see it, open your resources, read up. And the anti-VWF antibodies used only in severe cases. It rapidly halts the formation of microthrombi, but does not reduce the production of ADAM-TS13 inhibitor. Platelet count trend is the most reliable measure of the disease course. So your treatment would rest on quick plasma exchange, prednisolone, and probably rituximab. Now, this one, has anyone come across HUS? I mean, it's more of a pediatric thing. So Jaideep, you have more, I think pediatricians come across this one more, but in my final year of training in Adelaide, we have this annual Adelaide fair. So we actually had a bunch of kids and a few adults as well who came in with Shigella toxin-mediated HUS. So again, microangiopathic hemolytic anemia, which means Coombs negative hemolytic anemia with thrombocytopenia. This patient almost always will have AKI, history of recent diarrhea. So I'm not going to go into the E. coli stuff. In E. coli associated HUS, the undercooked meat is the most common culprit. So the one I'm talking about, that episode in Adelaide happened with undercooked meat, which was being sold by one particular person in that fair. 6 to 9% of Shigella toxin producing E. coli is complicated. Classically, 5 to 10 days, diarrhea followed 5 to 10 days later by Maha thrombocytopenia. A lot of them will need dialysis, but the overall renal prognosis is quite good. Most of them will actually come out well. 25% of them can have neurologic signs. Remember TTP, it was about 60 to 70%. Pancreatitis and occasional GI issues. So diagnosis is suspected on the basis of history. So 5 to 10 days back, there was diarrhea, then Maha thrombocytopenia. Now differentiating it from TTP, the platelet count here is not that profoundly low. It's usually over 40,000 and there is severe AKI. Remember in TTP, I said that the creatinine usually does not go over 176 and the platelet will be less than 30,000. So you need to confirm your diagnosis. You need to show the offending organism in stool, PCR, stool culture, etc. But sometimes they may have stopped producing live organism in the stool or passing live organism in the stool, so you may not be able to pick it. Renal histopathology will show the same thing that I mentioned before, but realistically, I don't think these people need a renal biopsy. And with that thrombocytopenia anyway, it will be very tricky to stick a needle. Treatment, hydration, so it's a supportive treatment, basically anemia, thrombocytopenia, hypertension. Plasma therapy does not help. Indications for dialysis are the same as for AKI due to any other cause. Most patients make good recovery, mortality rates less than 5%. Having said that, 5% of them may be left with significant sequelae, but compared to TTP, I think this is a lot more benign condition. Just moving on. Complement-mediated thrombotic microangiopathy. So previously it was called atypical HUS. This is from dysfunction of the alternative complement pathway. So again, you need to think HUS and TTP are probably much more common than this condition. Complement-mediated TMA, the AKI is much more severe in comparison to TTP. I keep stressing TTP, usual creatinine less than 176. Thrombocytopenia not as severe as TTP. So remember TTP, I said the platelet is almost always going to be less than 30,000. No history of diarrhea, which is kind of differentiating from E. coli HUS. There is an association with pregnancy. But remember, in my earlier slide, I showed you that the secondary causes of Maha with thrombocytopenia, HELP or severe preeclampsia can give you that picture. So you'll have to think carefully. It is a life-threatening syndrome and it needs prompt initiation of therapy. When do you suspect? Known family or personal history, significant AKI during pregnancy or postpartum. So remember, HELP syndrome, your patient should not come with significant AKI. If you've got significant AKI, you better start thinking, oh, am I looking at this one? And the classic TMA with progressive quick deterioration in kidney function, again stressing no abdominal pain or diarrhea history, and not exposure to drugs. And I'll come to the drugs later on. And ADAM TS13 is not low. Pathogenesis, basically what happens is the alternative complement pathway just goes mad and keeps going on and on and on and on. So either loss of function mutation in regulatory genes or gain of function mutation in effector. So loss of function in those which are supposed to inhibit and gain of function in the other group. Again, you do not have to remember all the details, but for those of you who are interested, you can look through it, things like factor I, factor H, etc. Okay, I don't know whether you can see this slide, but I just thought I'll just highlight the point that people, pregnant women who present with HELP syndrome have hemolytic anemia. They have low platelets. So how do I know? Is it complement-mediated TMA or is it HELP syndrome? So I'll let you have a look at that. So kidney function usually mild in preeclampsia HELP, severe in TTP, moderate in complement-mediated TMA, severe, usually mild or absent in TTP, and severe, typically dialysis required in complement-mediated TMA. And usually in complement-mediated TMA, you would have normal liver function. I mean, look, any systemically unwell patient may have some abnormality in the LFTs, but they won't be madly abnormal. Management, treat with eculizumab or ravulizumab. Now, again, this is something I don't expect you to remember, but if you come across this condition, if you strongly think this is what it is not very difficult to access these medications. So I remember Sandra had just joined, and there was one phone call, I spoke with you, and we soon had access. So things are, I think, much more streamlined now. They are monoclonal antibodies directed against the C5 complement component, basically the membrane attack complex, the last part of the component. These are antibodies directed against them. So the alternate complement pathway is unable to kill your cells. But please ensure meningococcal antimicrobial prophylaxis in addition to vaccination. Plasma exchange is not needed in this condition, so tread lightly with your plasma exchange. It's not to be, there can be significant side effects with that. Again, I'm not going to, I'm not an expert. B, guidelines keep changing. C, when you come across this, read up, find out the duration of appropriate treatment. And I'm sure by that time, by that stage, you would be talking about one of your hematology colleagues, or if the patient is in severe AKI needs dialysis, the nephrologist would be somewhere there side in the room supporting you guys. So again, eculizumab or ravulizumab, I think ravulizumab is easier to dose, weight-based, and also because you can spread it out over 8 weeks. But inpatient, I am told you have to start with eculizumab, and later on you might be able to switch them out. Drug-induced, so just have a look. I'm not going to read through that slide, but quinine is the one I think that I most worry about. And also be careful, some of the health supplements, especially from some of the Asian countries, are heavily loaded with quinine. So be careful, guys. Metabolism mediated TMA. So I've seen one severe condition because of vitamin B12 deficiency early on in my training days. So a last slide just highlighting the chief features. So TTP, renal failure, usually not severe thrombocytopenia. STHUS, renal failure is prominent but often reversible. And there is this story of bloody diarrhea, etc., and possible history of exposure to livestock or contaminated food. Complement mediated renal failure, usually quite severe, but thrombocytopenia less severe. And they have normal levels of ADAMTS13. And drug immune mediated, think about quinine. Look, there's no way you're going to remember all these drugs, but if you come across this condition, please quickly open whatever resource you want to use, up to date or whatever, and even good old Wikipedia sometimes, and see if they're on any of those drugs. So I'll just remind you of the plasmic score before I kind of wrap up. So platelet count, if ADAMTS13 is not available and platelet is deteriorating, so do we plasma exchange or not? Use the plasmic score. Platelet count less than 30,000, hemolysis, no active cancer, solid organ stem cell transplant, MCV less than 90 because they're ruling out B12 deficiency, INR less than 1.5. I think they're trying to say that it's not DIC. Yeah. So I'll just quickly go back and remind ourselves of this. So secondary causes could be pregnancy associated with severe eclampsia, HELLP syndrome, lupus, systemic sclerosis, antiphospholipid, severe hypertension, infections, DIC, stem cell transplant, organ transplant, bone marrow ablation, and calcineurin inhibitors. And I think I have come to the end of my talk. The 2 ways to live your life. One is as though nothing is a miracle. The other is as though everything is a miracle. So thank you, people.